Hello, my name is Chantal Kouokam Edwards. I'm a family nurse practitioner and a DNP student at the Saint Nation of Maryville University. Today I am pleased to present my DNP scholarly project titled Implementing an Algorithm-Driven Protocol for Hemoglobin A1C Monitoring in Primary Care. My DNP project committee member includes my chair, Dr. Joanne Kern. The second reader is Dr. Maria Snell. The community member is Dr. Stephen Nimbarji. Why choosing type 2 diabetes as a phenomenon of interest? This metabolic condition is widespread with a significant global burden. It affects 537 million people worldwide. 37.3 million are American, among which 12% are Floridian. It ranks as the 7th cause of death nationwide, with a devastating burden in our nation's public health resources, accounting for about $327 billion in medical costs and loss of wages yearly. The American Diabetes Association suggests that hemoglobin A1C is a gold standard for diabetes care and recommends testing at a regular interval to prevent the devastating complication of the disease. While there is plethora of evidence to support adequate disease management using guideline concordant care, many providers are still inconsistent in their adoption. So implementing an algorithm protocol tool allow nursing to use the pattern of knowing with harmony in the dynamic exchange with patient encounter. Consistency in using an algorithm tool decreases disparity in diabetes care, lowering healthcare costs while optimizing healthcare delivery, which is the goal of the advanced practice nurse. The next slide discusses the purpose and aim of this study. The purpose of this project was to assess if using an algorithm protocol in clinical decision making impacted provider adherence to American Diabetes Association guideline for monitoring A1C in patients with type 2 diabetes. The specific aims were first to increase hemoglobin A1C testing rates, second, to improve glycemic control, third, to optimize therapeutic management, and fourth, to reduce the frequency of unplanned hospitalization for acute metabolic complications. The review of literature was completed, doing a search history and assessing databases such as Cigna, Medline, and PubMed. The search using keyword and specific inclusion and exclusion criteria identified 72 articles, among which 22 were found relevant to address the clinical inquiry. The review of literature identified common themes, which were first, the cumulative risk of complication in diabetes, second, the barrier to provider non-adherence, third, the intervention for guideline concordant care, And fourth, the impact of hemoglobin A1C testing on patient outcome. A theoretical framework was used to support our implementation. The Aitchison planned behavior theory provided an excellent framework that helped understand the complexity of practice and explore the determinant of providers' behavior. Aitchison theory posits that an individual choice to perform a specific behavior depends on his attitude toward that behavior. The subjective norms, the performance ease, the perceived behavioral control, and behavioral intention. So, implementing an algorithm-driven protocol using the planned behavioral theoretical framework provided a robust assessment of provider behavior and addressed the obstacle to diabetes guideline compliance, leading to optimal care provision. On the next section, we address the method used to support this scholarly project. A quantitative exploratory design through a retrospective chart review was used to evaluate the pre compared to post-intervention outcome measure for this study. The method was excellent as it was important to contrast outcome before and after intervention while answering the clinical question effectively. The strategy involved a provider educational session, then adapting an algorithm protocol from the American Diabetes Association Standard of Medical Practice, embedding the tool into template, and blending it through practice workflow EMR. Having provider using the algorithm in decision making to order hemoglobin A1C testing as appropriate and adjust treatment as needed. At the end of the trial, the data collection sheet was to be used to collect the data for an analysis. This is a display of the algorithm-driven protocol for monitoring progress in type 2 diabetes management with A1C testing. Again, the tool was adapted from the American Diabetes Association Standard of Medical Care in Diabetes 2022, abridged for primary care provider. The next section discusses the population sample. The project was conducted at an outpatient facility located in the southeastern U.S. It involved a retrospective chart review of all gender adult 18 to 64 with type 2 diabetes. As presented in this pie chart, the population sample was about 40% African American, 25% Caucasian, and 35% Hispanic and other group. This population sample represented the general characteristic of residents living in this area. So, implementing an algorithm protocol that improved diabetes care, reduced health disparity common in the population living in the area. The next section discusses the data analysis. The statistic analysis was processed through SSPS using the z-test for the differential of two proportions. It helped evaluate the ratio of A1C testing adherence, treatment or care plan adjustment, and impact on hospitalization for metabolic complication between the pre- and the post-interventional group. In addition, the Wilkinson sign rank test evaluates the impact of guideline concordant A1C testing on glycemic targets. The result of the study are going to be discussed in this next few sections. The results showed a statistically significant difference in pre versus post-intervention group. The hemoglobin A1C testing ratio improved by 60%, while the treatment and care plan adjustment increased by 31%. In addition, hospitalization for metabolic complication decreased by 90%. Patients achieving their hemoglobin A1C target increased by 12%, while 30% got out of the critically high margin. The next slide displays a visual summary of the overall result of the study and the outcome analysis through the data collection sheet, presenting the pre- and the post-intervention populations and different percentage. The result of the A1C check are also displayed in this pie chart for the outcome analysis of A1C check. In the pre, we have 31%, and in the post, we have 69% compliance with A1C target and check. The next slide is a table summarizing the z-test for the difference of two proportions in the outcome evaluated. In the next section, we're going to be discussing limitation of these studies. One of the first limitations of this research study is that the variability in subject characteristic revealed a crucial issue of heterogeneity and selection bias that limit generalization of result finding. In addition, the short duration of the study and single practice implementation site may have affected the result, limiting generalization. Finally, careful utilization of statistical tests for evaluation is critical. For instance, the Wilkinson test used for homogeneity assumed that the variable for participants in the scholarly research study were all equal. Thus, the reliability of the finding could have been challenged, thus limiting generalization of result. The next section is going to discuss the overall findings. Outcome finding in this study shows statistically significant difference between pre- and post-interventional group and evidence of an improvement in glycemic target, increase in the ratio of hemoglobin A1C testing per guideline, increase in the rates of care adjustment, and a decrease in the frequently unplanned hospitalizations for patients. These conclusions are consistent with prior evidence showing that algorithm protocol lessen provider clinical decision ambivalence, leading to guideline concordant care with care plan modification, thus averting unplanned hospitalizations. These results impact patient quality and safety and significantly optimize healthcare delivery as a whole through saving costs. Future study can minimize bias by improving study duration, extend study implementation sites, improve blinding and participation selection process to optimize result validity. Designing and enacting evidence-based health policy can also improve access to high-quality diabetes management among poor and racial minority population. The next section will discuss the implication of this research study in practice. Successful implementation of an algorithm protocol in practice helped with standardized diabetes care by heightening provider awareness in decision making. This reduced disparity in diabetes, preventing harm to patients and optimizing equity in care. Furthermore, the study generates savings by improving diabetes health outcome, preventing frequent hospitalization, preventing financial loss for organization, and making this project an organization necessity for my healthcare institution. The next section is going to discuss the overall conclusion of this research study. Diabetes is a chronic disease that is raging to epidemic proportion worldwide. The staggering financial costs and increased prevalence of this chronic metabolic condition provide compelling argument for preventative medicine. The American Diabetes Association evidence-based guideline recommend screening at-risk patients and providing recommended lifestyle modification program to optimize diabetes care. In addition, timely A1C testing and monitoring allow clinicians to make medication adjustment to reach the A1C target. Despite considerable evidence available to inform diabetes management, suboptimal care remains frequent in practice. Implementing an algorithm protocol with the scholarly project prompted providers to use American Diabetes Association A1C testing and monitoring recommendation for patients who met guideline criteria. A tool such as algorithm protocol to support clinical decision making has shown to improve outcome in type 2 diabetes in primary care setting while reducing the burden of the disease on society. Consistency in using this tool was effective to standardize care delivery, thus decreasing variability and disparity in care while improving diabetes population health outcome. My personal journey through this doctorate practice and achieving the implementation goal was empowering. As a doctorally prepared primary care provider nurse practitioner who serve various groups of low income and racial minority with higher prevalence and burden of diabetes, using an algorithm tool that facilitates appropriate disease process was a priority for me to achieve health equity in our community setting. The learning experience provided the leadership skill needed to leverage policy and develop an organization protocol that addressed disparity in diabetes and optimize equity in care. Thank you for the opportunity to listen to my presentation, to present this presentation. I am welcoming any question and any clarification. The following slide display all the references used in the presentation. Blessing to all.